Hello everyone, welcome back. Today I'll be covering Cubitus varus of the elbow, a simplified version. Started off as an introduction, basic anatomy, pathogenesis and pathoanatomy, the clinical presentation, interpretation of X-rays, and outline of treatment plan. This figure shows the S-shaped deformity of left upper limb that can be found in a supracondylar fracture humerus in children. Now let's get started. As an introduction, elbow varus deformity, also known as Cubitus varus or gunstock deformity. It is the most frequent complication of supracondylar humerus fracture in children. It causes lateral prominence of the elbow area. Cubitus varus is a triplanar deformity. There is a combination of varus, hyperextension, and internal rotation. This figure shows the patient that present with a cubitus varus with a gunstock deformity present. As illustrated, you can see it mimics the gun. Factors for malunion supracondylar humerus are 1. Impacted or comminuted type 1 supracondylar fractures. 2. Rotationally unstable type 2 fractures treated in a cast with subsequent loss of reduction. 3. Poorly stabilized or reduced type 3 fractures or delayed neglected fractures. Other causes of cubitus varus include A. Infective cause, medial growth plate damage. B. Vascular cause, causing a osteonecrosis of the trochlea. C. Traumatic cause, example a lateral condyle fracture. D. Neoplastic, usually secondary to exostosis in distal lateral humerus. E. Congenital cause, due to epiphyseal dysplasia. Regarding the anatomy, the distal humerus and the proximal radius and ulna forms the elbow joint. It is one of the complex joints in the body, allowing flexion, extension, pronation, and supination. In full supination and extension, the elbow joints deviates between 5 to 15 degrees in the coronal plane known as the carrying angle or physiologic valgus of the elbow. In cubitus varus, the carrying angle decreases and the hands are closer to the midline than expected. This figure shows the left upper limb of a patient. Normal at the midline, you can see there is a physiological valgus. In cubitus varus, you can see the hand is closer to the midline and there is a lateral prominence of the lateral condyle. For cubitus valgus, you can see the hand is away from the midline. The history, including the previous history of fracture. Physical examination. During inspection, there is a wasting of muscles, any presence of scars that indicate previous open wound, any sinuses, that means infection or redness. there will be hyperextension deformity, limited flexion, medial tilt and lateral angulation at elbow, prominence of lateral condyle humerus. This figure shows the cubitus varus. You can see the hand is deviated towards the midline and prominence of lateral condyle. After look, we feel. So on palpation, there is thickening and irregularity of supracondylar ridges. Lateral condyle appear prominent due to rotation of distal fragment. There is a decrease in carrying angle. 3-point relationship do not make an equilateral triangle. This figure shows the 3-point relationship. At the posterior view, we should see the tips of the medial epicondyle, lateral epicondyle, and olecranon forms a triangle when the elbow is in 90 degree. During full extension, the tips of the medial epicondyle, lateral epicondyle, and olecranon should be collinear in full extension. Next, move. Rotational malalignment is determined by evaluating the differences in shoulder passive internal rotation in extension between the involved and uninvolved extremity. Always do a complete neurovascular examination. For radiological examination, A. Bowman's angle has been described in my previous video. Supracondylar fracture humerus in children simplified version is more comprehensive there. Please go to the video. B. Humerus elbow wrist angle of Oppenheim. The humerus elbow wrist HEW angle of Oppenheim is determined on a antero-posterior epiradiograph of the upper limb with the elbow in full extension, about 180 degree, and supination. The angle is measured between the humerus shaft axis and the forearm axis. The humerus shaft axis is defined by the midpoints of two lines perpendicular to the shaft. The forearm axis is defined by the midpoints of two lines perpendicular to the forearm bones, that means lateral border of the radius and medial border of the ulna. Less than 5 degrees, we consider is cubitus varus. This figure shows the humerus elbow wrist angle of Oppenheim. As you can see, the humerus shaft axis is defined by midpoints of two lines perpendicular to the shaft, and the forearm axis is defined by the midpoints of two lines perpendicular to the forearm bones. The intersection, and we get the angle. The severity of cubitus varus is graded by grade 1, loss of the physiological valgus angle. Grade 2, 0 to 10 degrees of varus. Grade 3, 11 to 20 degrees. And grade 4, more than 20 degrees. Complications of cubitus varus. Mostly cosmetic deformity with little functional significance with devastating long-term complication. These include 1. Chronic pain, 2. Tardiana nerve palsy, 3. Posterolateral rotatory instability, 4. Snapping elbow, 5. Increased risk of lateral condyle and other secondary fracture. Regarding management, cubitus varus deformity has no tendency for spontaneous correction, but it always has to be corrected. The treatment options include 1. Observation with expected remodeling. It is not appropriate because although hyperextension may remodel to some degree in a young patient, in an older child, little remodeling occurs even in the joint planes of motion. Hence, it is not recommended. B. Hemiepiphysiosis and growth alteration. It is used to prevent cubitus varus deformity in a patient with medial growth arrest and progressive deformity, rather than correcting it. It has no role in a child with a normal physis. C. Corrective osteotomy. Osteotomy is the only way to correct a cubitus varus deformity with a high probability of success. Corrective osteotomy options include 1. Medial open wedge osteotomy, which causes lengthening of medial aspect of humerus causing stretching of ulnar nerve. Number 2. Lateral closing wedge osteotomy with or without simultaneous correction of rotation, also known as French osteotomy. This figure illustrates the lateral closed wedge osteotomy. You can see the measurement carried out prior to osteotomy, and the highlighted bone is removed and then closed to get a proper angle post-operatively. This figure illustrates an X-ray during extension in a patient who has a right cubitus varus. Post-corrective osteotomy X-ray at 3 months by using a screw plate and wire. And another side C is 8 months post-surgery. Other corrective osteotomy options include 3. Step cut osteotomy, 4. Arch osteotomy, 5. Pentalateral osteotomy, 6. Oblique osteotomy with derotation, 7. Dome osteotomy. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.